training since its inception in 1995. Mike is also responsible for the design and development of EMSoft, SMC's emergency action planning and auditing application. In 1998, Mike patented the FM Extractor, the emergency face mask removal device that is described as a necessary component of every sideline emergency kit. Mike dedicates much of his professional practice to the development of practical information and techniques regarding on-field management of sports emergencies and to ensuring that the 2-minute or less curriculum provides unparalleled, true-to-life emergency response training for sports medicine professionals. Mike's work has been incorporated into many peer-reviewed works, reference texts, and a National Athletic Trainers Association award winner software application. Two of Mike's more recent scholarly endeavors have been recognized by the Journal of Athletic Training for Best Non-Research Manuscript and Best Research Manuscript. Under Mike's direction, the In 2 Minutes or Less training curriculum has become the foundation of many of the most elite medical teams' emergency action plans. A truly dedicated and traditional athletic trainer, Mike prefers the sidelines to any other practice setting. He can be found on any given Friday on the sidelines of Livonia Central School District. Welcome to Spats, Mike.
Well, thank you very much. I appreciate the opportunity to come down and do a presentation in this area. This is absolutely beautiful place to come and have to work for a little while. So it's not bad. I have a 2-hour presentation scheduled, and then I get a couple of days to stay here on the island. That's not a bad gig. So I'm pretty pleased with that with this opportunity. What I would like to do is maybe a little bit of a different style of a presentation. I like to present this type of material in a very pragmatic way or a very practical way. And as we look at arguments or discussions in the literature about the way certain emergencies are supposed to be handled, there's always questions, there's always opposing opinions, and there's a lot of things that present a lot of confusing points of interest in the literature, and oftentimes leaves us feeling a little disoriented about the way things should be handled. Hopefully I can present to you today a little bit of a thought process that can help you clear up some of those things. And when you read things in the literature, maybe look at those a little bit differently, and in doing so, help clarify the way that you should be responding to emergencies on the field, be it an equipment-laden athlete or be it someone that doesn't have any equipment on, regardless, okay? And a lot of this information that I'm going to be presenting to you is evidence-based in that it's coming from observations made during 23 years of teaching the In 2 Minutes or Less evidence-based program. But I want to tell you a little bit more about where I'm coming from, because I think, again, my background is a little bit different in terms of the way I present the information. I present it to you very practically because I present it to you in a way that I have to use it on Friday night, just like you would have to use it on Friday night. So hopefully you'll see that coming through in the presentation. The bio that was read about me, which was very flattering, by the way, thank you, described me as a traditional athletic trainer, and I believe I am very much a traditional athletic trainer. I love nothing more than the smell of grass and turf on a Friday night or a Saturday morning. I absolutely love the smell of turf. In fact, my wife got me a Yankee candle that is turf. It's actually football turf. When you burn it, it smells like turf. So, and on Friday night, I can honestly say there is no place that I would rather be. Saturday evenings, there's no place I'd rather be than in the gym watching basketball. So much so that I live just down the street from where our stadium is, and before I was an athletic trainer at that school, I couldn't stand the fact that it was Friday night and the stadium lights were on and I wasn't there. So I very much chose the right career path for myself, let's put it that way. And that path to athletic training was a very familiar one to a lot of you that are out there. I was an athlete myself. The high school jock transformed into I played a little bit in college as well till I had an unfortunate injury, fractured dislocation in my shoulder that left me unable to play. So I couldn't stand not being around athletics and athletes for that long, so naturally, like a lot of you out there, probably led me to the athletic training profession. I went on to get my master's degree at Ithaca College in exercise science and physiology, and it was at that point where my career path took a little bit of a different twist. I had this idea that I was going to be an athletic trainer and I was going to work my way through the ranks, and my dream was to be an athletic trainer in the National Football League. My career path took a pretty interesting twist right off the bat when I was in grad school, and we had an accident with a wrestler at Ithaca College. It didn't look like anything in particular. It didn't look like anything that was out of the ordinary for anything that we see on any given day. But later on, that athlete's father took him to the hospital because he was splinting up in the back of his neck, and it turns out he had a fracture in his cervical spine that we completely missed. It turns out it was a fracture in the transverse process. So if you're going to miss a spinal cord injury, that's one to miss, because the transverse processes aren't going to lend a whole lot of instability to the cervical spine. But the next day I walked in to the office thinking I was going into the training room to start another day of rehab with the wrestling program, and I was confronted by the president of Ithaca College, the athletic director at Ithaca College, as well as the emergency room physicians from Tompkins Community Hospital. And they all wanted to know why I let this kid walk off of Ithaca College's campus, and why he had to be taken to the emergency room hours later with a fracture in his cervical spine. And when it all came down to it, the emergency room physicians sat me down and told me, it's not your job to decide who goes to the emergency room and who doesn't. It's your job to see the mechanism of injury and transport that person to the emergency room. So afterwards, after something like that happens, of course, you start backboarding and transporting everybody. Because think about it, with a spinal cord injury or a head injury, what are the mechanisms of injury that we're going to transport somebody? We could have axial loading, obviously. This one was an axial load, by the way. But you could also have rotation and flexion. You can have rotation and extension. You can have lateral bending. All of those can result in spinal cord injury, either fracture in the vertebral column or neurological damage. So it was later on that I realized, wait a minute, as an athletic trainer, it is my job to decide who goes to the emergency room and who doesn't. It is my job to decide if this warrants being transported or if it doesn't warrant being transported. Imagine on starting here in August, if you transported every football player that came over to you with a headache or with pain in the back of their neck in the first 2 weeks of football season. That's all we would be doing, would be transporting athletes all day long. And then I left Ithaca College and I went to the University of Buffalo, where I was an athletic trainer at the University of Buffalo, and that's when things took a real turn for me. And I call this the day. And when I left Ithaca College and I started at UB, and tell me you guys don't understand this, all right? You graduate, you get certified, right? You pass your National Athletic Trainers BOC exam. You're feeling pretty good about yourself, right? So I find myself back at the University of Buffalo, an athletic trainer with the football program. I'm sitting on the golf cart. It's August. It's 85 degrees out. I'm sitting on a golf cart wearing my sunglasses, chewing my seeds. It's a pretty good job, pretty good gig. All right, and that's what we all got into this profession for. It's a pretty good gig when you think about what we get paid to do, okay? But then there comes the day, and that is the day that you're confronted with a potentially catastrophic injury, and all of a sudden you realize what the ultimate part of your job really is. And you realize that if you are not prepared for that incident, if you are not prepared for that day, no one else on that field is prepared for that day. And it's likely that you are going to be the one that makes the difference between whether that athlete walks away from that injury, survives that injury, or doesn't. Okay? And I refer to that as the day. If you've experienced that day, then you know exactly what I'm talking about. your job is different from that point forward. All of a sudden, you're on the sideline. It's not so cool to be the athletic trainer out there sitting on the golf cart with your sunglasses on anymore. Because now you're looking out over the field and you're thinking to yourself, any one of these athletes could just fall over at any time for any various number of reasons. And I'm the one that's responsible for making sure that they get back up again. All of a sudden, you can't watch a football game on Sunday without looking and saying, I've never seen that helmet before. What type of fastener is that that's holding that face mask? I don't think I could get that off if I had to. It's different, okay? It's a lot less fun after that day. If you haven't experienced that day, there's not a whole lot we can do to prepare you for that. You can do your CPR training. You can do all the advanced care training that you want to do. But trust me, you are not prepared for that to happen until it actually does happen to you. And then once you've gone through that, once you've experienced that day for yourself, you'll realize just how unprepared you are. And you'll be more scared moving forward because you'll know exactly what can happen on any given day. Okay? So I say that just because that is kind of the reality of what we are doing on a day-to-day basis. This is a great profession to be in. It's a very exciting profession to be in. But don't forget the ultimate part of your job and what you're there to do. Everybody in this room can tape ankles. Okay? In order to travel with the football program at the University of Buffalo, we had to be able to tape an ankle in under 2 minutes with no wrinkles. Big deal. All of us in that room can do that. Okay? But how many of us in this room, if an athlete collapsed, could do high-quality CPR? And I don't mean that you can pass your American Heart Association test. I don't mean if you're CPR certified. How many of you can have the right depth of compression? How many of you can have the right rate of compression? How many of you can operate an automatic external defibrillator without any delay in compressions? Because it's that type of thing that we're expected to do. It's part of our practice act. It's what we're expected to do on a daily basis. The irony of this is a picture of me playing high school football. Why is that ironic? Because there's the definition of an axial load mechanism. So that's what I did on a day-to-day basis when I was in high school, and now I'm up here preaching why not to do that and how to manage things when that mechanism of injury results in injury. So I do have to say, before we get into a lot more of this material, that I have some significant conflicts of interest with this topic that I'm talking about. I have an extreme commercial interest in the In 2 Minutes or Less Sports Emergency Care Action and Emergency Action Planning Program. That's what I do for a living. I teach that curriculum, and a lot of the information that I'm presenting to you is based on that. My company manufactures and sells the FM extractor for emergency face mask removal, so I have an extreme bias there in terms of face mask removal and those types of protocols. We also make the Team MSoft Emergency Action Planning software platform, so I have a bias in terms of emergency action planning that I want you to be aware of. But I also want you to know that truly, I could care less whether you use the FM extractor. I could care less if you use Team MSoft's application for your emergency action plan. What I care about is that if you and I are ever on opposing sidelines of a basketball game or a football game, that you are as prepared as I am for that day. Because I'm a high school athletic trainer and I'm by myself. You're probably a high school athletic trainer and going to be by yourself on the other sideline. So if something happens, we're going to be relying on each other. I can tell you if one of my players goes down, I'm as prepared as you possibly can be prepared. And I'm not saying that I can do things any better than anybody else, but I can tell you that I've taken it to the nth degree to make sure that I'm prepared for that. The only thing that I care about is that my colleagues in this profession are the same way on the opposing sideline. So 23 years of the In 2 Minutes or Less curriculum has provided very valid practical information, expert opinion, and pragmatic approach that I think is worth sharing. So if you'll take into consideration my bias, also take into consideration where I come from as an athletic trainer, hopefully I can share some of these experiences with you and we can all walk away with a little bit of a better understanding of maybe a better approach. So why is it in 2 minutes or less? Well, the American Heart Association in the chain of survival says that we have how long to get somebody defibbed if they go into cardiac arrest? We have 4 minutes, okay? That's 4 minutes for the lay rescuer, but we're not lay rescuers. We're sports healthcare professionals. We're athletic trainers. And we have a couple of things at our advantage when we're looking at sports emergencies. We know if it's going to happen. We know who it's going to happen to. There's players on the field. There's players on the court. Referees, probably, right? More than likely referees and coaches, but that's a topic for another day. So we have athletes, for the most part, so we know who it's going to happen to. We know when the emergency is going to happen. It's going to happen in the span of those 4 quarters. It's going to happen in the span of those 4 quarters of basketball, okay? So, and we know where it's going to happen. We've got a 100-yard field. We've got a basketball court. So we have a lot of things at our advantage. Is there any reason you can think of to not be ultimately prepared? We know who it's going to happen to, when it's going to happen, and where it's going to happen. So there isn't any reason that it should take 4 minutes for us to get a defibrillator on somebody and defib them for the first time. So my thought process is, if it takes the lay rescuer 4, then we should practice to have that done in 2. If we can do all of that stuff in 2, then when real life stuff gets in the way of what we're trying to accomplish, when nerves and jitters and things aren't exactly where they're supposed to be, we still have 2 more minutes to get all that stuff sorted out, and we're still well within that 4-minute period. And I can tell you from our programming, from the programming perspective, that when we plan and we have an emergency action plan and we have teams that go through that emergency action plan and practice that emergency action plan, you should see how flawlessly critical care tasks are performed, and we beat that 2-minute mark on a regular, consistent basis. All right, so 2 minutes is even a lot of time when we have all the preparation in place, the practice in place, and we are efficient with what we have to do. Our program goes through an annual systematic review. So a lot of this information is going to be based on peer review literature, but also contributions we've made to the literature. If you go to our website at sportsmedicineconcepts.com, you'll see a place on there for a lot of the literature that this program is based on. Type in the password "respond flawlessly" and you'll have access to all of the information, all of the peer-reviewed works that we use in this process, and then I'm going to be covering in this presentation. So there's a good reference for you. We also spend a lot of time in the 2 minutes or less process gathering expert opinion. That's all part of the evidence-based practice. There's 3 prongs to that evidence-based practice. Okay, and one of those is expert opinion. So what's really neat is we get to take all that peer-reviewed literature, all that information, and we take it all over the country. We take it to athletic trainers in the clinical and outreach setting. We take it to professional teams. We take it all over the country. We take that information out and we actually apply all of that information and see how it works. So we take what we read about in the literature, we take that out onto the field and say, all right, well, it worked in the lab. How does it work Friday night on the field? How does it work on turf? How does it work on ice? Does that really work for us on Friday night? And we also gather expert opinion. What do paramedics think about this? What do trauma physicians think about this? What do athletic trainers in Texas think about this versus athletic trainers in New York? What's the difference in opinion regionally? So we get a good cross-section, we get a good data pool, and it's a multidiscipline data pool. And then as I said, we apply all of that stuff in practical, real-life scenarios to see how it actually works. So my objective then today is to share with you what we've learned from this process that we use in the 2 minutes or less program. I won't be delivering a spoon-fed flowchart for you in terms of how to do high-quality CPR or how to remove equipment from an equipment-laden athlete. We won't be spoon-feeding that information to you, but rather I hope to demonstrate a cognitive process that provides you the opportunity to think your way through any given situation. Because when we do the in 2 minutes or less program, and we do final checkouts, benchmarks, and competency reviews in that program, we can create a certain scenario and make you test out on that scenario. But what is the likelihood that that scenario that we just set up for you is what's going to happen Saturday afternoon when it happens in real life? It's probably not very likely that we're going to hit it right on the mark. So for us to be able to practice every way that an emergency is going to happen is not realistic. So what we do is we teach a pragmatic approach, a cognitive approach, an approach that gives you the ability to stop and think your way through every single step in the process. And hopefully that's what we can deliver to you this afternoon. All right, so the next thing I want you to do is put your pencils down, because we're not going to take notes. Because I'm going to present this, I hope, anyway. I'm going to present this to you in such a manner that it's just blatantly obvious how to move forward from this point forward. All right? If you need any information following this, you can always just contact me. I'll get you whatever information you need. I can send you follow-up information to read if you want on a particular topic. You have access to all of the peer-reviewed works that I'm basing a lot of this stuff on. But really, I think at the end of the presentation, hopefully what we get is an understanding of the process that is just innately obvious. And we start with an emergency action plan that's based on a critical care triangle. It's the foundation of any effective emergency action plan. And that critical care triangle is made up of an A person at the head and neck and a B and C person at either shoulder. All right, so how many athletic trainers are in high schools that are all by themselves and don't have two more people that can make up that critical care triangle? Probably quite a few, right? Well, so am I. Okay, but unfortunately, that's not an excuse. At my high school, I'm the only athletic trainer there, but I never step out onto the field without a critical care triangle in place. If you have other athletic trainers because you have a staff, that's great. That's good for you. This part of it's easier for you. If it's not, it's a little bit harder, but it's your job. So it might be a little bit harder for you, but it's your job. That's what you're there to do. As I said before, we can all tape ankles in less than 2 minutes. And especially on the sideline, when you're doing it on the bench, it looks real impressive when you're just doing all the figure eights continuously and it all looks good. Okay? But what are you really there for? Okay? You're there to make sure that in an emergency, that emergency is cared for in the most appropriate manner. That's one of the most important jobs that you're servicing, or that you're providing. So if it's really hard for you to put together an emergency action plan, I feel for you, but it's your job. So to fill in that critical care triangle, you may have to make use of coaches, your head coach, your assistant coach. And I know that raises everybody's blood pressure, and half of you in the room are thinking, no way. Because I know, except at my school, but I've put a lot of time and effort into this, I can honestly say. But for the most part, I know, I get it. When something really happens, you kind of want to tell your coaches, just go as far away as you can and just let me handle this. I get that. But in this case, we can't do that. If you're all by yourself, you need that critical care triangle in place. So it may take some effort, it may take some time to train your coaches to be that B and C man. Your emergency action planning should be the hardest thing that you do, and it should be the most time-consuming. So we have the critical care triangle, and then we have what I call the red kit philosophy. So the red kit philosophy is the way that you operate the critical care triangle. When you have your triangle in place, those three first responders to that athlete, their job is to provide critical care for that athlete. Those three people never leave the side of the athlete. If you need a defibrillator, somebody else brings the defibrillator to you. Okay? A critical care triangle individual doesn't leave the side of the athlete to go get something. Those things are brought to them. Those are the people that are going to be doing CPR if need be, taking care of emergency situations, completing critical care tasks if need be. And that critical care triangle operates under a red kit philosophy. And this is where I think hopefully it gets to be a little bit more obvious, because we could all debate, and it's in the literature quite a bit. Do we put somebody on a spine board anymore? We all know the debates about spine boarding, right? The trend now is we don't spine board anymore. EMS just puts them in a soft collar and puts them on the gurney. We don't use spine boards anymore. We don't log roll anymore. There's a lot of literature out there that says we shouldn't be log rolling anymore. We should be flat lifting, 6-person lift. Okay? Well, I can tell you that for every article you find that says the flat lift is better than the log roll, there's going to be a situation where the flat lift doesn't work. Okay? Are you going to flat lift a 350-pound offensive lineman? Maybe, if you have 6 people that know how to do a really good flat lift. But the reality is, not many of us are going to be able to pull off a 6-person lift on a 350-pound offensive lineman. I'll give you another example. Are you going to flat lift a 220-pound goalie on the ice? I don't know. Maybe you will. Okay? So the idea here, or the take-home message here is there's going to be an appropriate time for a flat lift. There's going to be an appropriate time for a log roll. There's going to be an appropriate time to use a spine board. There's going to be an appropriate time for the scoop stretcher. So for me to stand up here, or for any other person to stand up here and say, we're not going to log roll anymore, best practice standards say to flat lift, I can't agree with that. Because I've seen too many times where a flat lift is just not an appropriate transfer protocol in a given situation. So in our red kit philosophy says, as athletic trainers, it's our job to know how to flat lift. It's our job to know how to log roll. It's our job to know how to log roll push. It's our job to know how to remove the face mask from any football helmet that is on the market. It is our job to be able to remove the helmet without the shoulder pads. It's our job to be able to remove the helmet and the shoulder pads all at the same time. It's our job to be able to do all of that stuff. But more importantly, it's our job to know which one of those procedures is most appropriate for the situation that we find ourselves in. Okay? So on Friday night, I may find myself in a situation where the flat lift is appropriate. The next Friday night, you may find yourself in a situation where flat lift just isn't going to work. Or we may be on one night, we may be able to get the shoulder pads and the helmet off of a person when they're just laying on the turf flat on their back. Another time, that maneuver might not work, and we have to do a torso lift technique to get the equipment off. Okay, so to say that one technique is so much better than another technique, that those are the techniques that we now use, I don't think that's appropriate at all. I think we need to have all of these strategies in our kind of mental kit on the sideline, and we pull the things out of that kit as they're most appropriate to the situation that we find ourselves in. And then we operate under what I call as a primary objectives approach. Every time we step out onto the field after an injured athlete, what are our primary objectives? Every single time we step out onto the field. Our primary objectives are cardiac, airway, breathing, and maintain neurological status of the athlete. Those 3 things are our primary objectives. It just so happens that 9 out of 10 times the kid's laying on his back, rolling around, screaming at the top of his lungs, vulgarities, all those kinds of things. That's when, I don't know about you, but that's when I move fast enough so that moms and dads that are in the stands think that I'm concerned and I'm getting out there after their son or their daughter really fast. But in reality, I'm not moving as fast as I could be because I know cardiac, airway, and breathing are fine. I know neurological status are fine. I'm going to let them blow off a little bit of energy before I get out to them. And then we'll gain control of the situation. On the flip side of that, what if your athlete is face down, they're not moving? That's when you have an actual run out to the field, because then you don't know the status of cardiac, airway, breathing, and neurological status of the athlete. That's when you are moving at top speed, because you want to find out what the status of that is right away. So those are our primary objectives every single time. It just so happens that, thankfully, most of the time when we step out in the field, we already know what the status of those objectives are. Now, that's an important thing to consider, what your primary objectives are, because what I'm going to suggest as we get into this a little bit more and more, my suggestion to you is anytime you come up with a question about whether you should I remove the helmet or should I remove the face mask? Should I leave the face mask on, or should I take the helmet off and the shoulder pads? Or should I take the helmet off and leave the shoulder pads on for now? Anytime you find yourself asking yourself that question, Or if you're about to raise your hand and ask that question, just stop for a minute and ask what your primary objectives are. What is my primary objective at this very moment? It's to breathe for the athlete because they're in respiratory distress. What is in the way of me accomplishing that task? It might be that the face mask is in the way. All right? If you remove the face mask, now you have access to the airway and you can do what you need to do. None of the other equipment is in the way of what your primary objective is at that point. It might be later on, but what is your primary objective at that point? And what do you need to do in order to reach that objective? If your athlete's not breathing but they have a pulse, what's your primary objective? To breathe for the athlete. We can remove the face mask, or worst case, we have to remove the helmet. We can start breathing for the athlete. The shoulder pads have no bearing whatsoever on that. So if we mess around with the shoulder pads, the only thing we're doing is delaying what our primary objective is. We're delaying breathing for the athlete. So we leave those shoulder pads on. They'll be problematic later on for sure, and we'll deal with them then. Okay, so always ask yourself, what is my primary objective right now with what I'm being faced with? And we're going to come up with different answers. If I'm presented with the exact same situation that you're presented in, and I ask myself, what's my primary objective and what do I have to do to meet that, I could very well come up with a totally different solution than you do. And that's fine. I may decide I'm going to flat lift. You may decide I'm not going to flat lift. I'm going to log roll. Okay? If we both protect the neurological status of the athlete during that transfer protocol, who's right and who's wrong? Neither one of us are wrong. Okay? So think of it in those terms. Protect those primary objectives, and don't worry about, well, the position statement says that I'm supposed to do it this way. Well, the position statement is a suggestion. It's a guideline. But your overall guiding rule is cardiac, airway, breathing, neurological status of the athlete. I refer to those primary objectives as a cabin. So we're going to check the status of our cabin. If the cabin is appropriately cared for, then we're both right. And what about liability then? Because I know there's questions about liability. Well, the position statement says that we're supposed to respond this way. The position statement says that we're supposed to remove equipment from an injured athlete pre-hospital before they get transported to the emergency room. If we don't do that, are we liable for the outcomes because we didn't follow the position statement? Now let's think about it in a different way. What are your true objectives in caring for that athlete? Is your objective to remove the equipment from the athlete? Is that an objective? Absolutely not. Your objective is to protect cardiac, airway, breathing, neurological status of the athlete so that athlete has a better chance of surviving that accident. So if you compromise the primary objectives in order to meet the established guidelines of a position statement, where's your liability? Your liability stands in the outcome. So the cabin is your ultimate responsibility. So let's take a walk through the cabin then. If we walk through the cabin on any given emergency situation, we have a couple of different topics we're going to look at: repositioning, assessment, cardiac, airway, breathing, and neurological status. So our primary assessment, of course, we're going to gain control of the scene and determine the extent of injury. At this point, I think it's important, especially with a face-down athlete, I think it's important that you gather yourself, gain control of the situation, and determine the likelihood that you're going to transport that athlete. It's kind of a fancy way of just completing your American Heart Association or the American Red Cross primary survey, right? Check the level of consciousness. Are they responding to you? Because if they're alert and responding to you, that's a different scenario than if they're not alert and responding to you. Now, as far as repositioning goes, we have a couple of different options available to us. We can log roll push. But you can see here where we can't eliminate the log roll from our practice because there is no other way to get a face-down athlete to face-up position. We're going to have to log roll or log roll push that athlete. And then we want to place them immediately into cervical neutral position. And that's an important step. what we find in the literature is that if we bring somebody to a supine position and we bring them into neutral cervical position within 2 minutes of the accident, the 2 minutes corresponds to the name of the course simply by accident. All right, 2 minutes is actually in the literature as a benchmark time frame. If we get that person into neutral cervical position within 2 minutes of the accident, they have a significantly better chance of walking away from that injury than if it's outside of that 2 minutes, which is pretty interesting because prior to the recent position statement from the NATA, prior position statement said that we should stabilize the position of the athlete in the position they're found. Okay, but what would happen when EMS arrived on scene? So you and I, as athletic trainers, we keep them in the position they're found as long as possible. As long as airway, breathing, and cardiac and all that were fine, we'd leave them in the position that they're found. What does EMS do as soon as they arrive on scene? They put them into neutral cervical position. They're going to do that every single time. Okay? The only difference is when we wait for EMS to do it, average response time on a good day is about 6 to 8 minutes for EMS. That's on a good day. So they're going to reposition them at 6 to 8 minutes. It's well outside of the 2 minutes where they have the best chance of recovering from that maneuver or have a better outcome as a result of that maneuver. So therefore, the position statement now says that we should reposition that person into cervical neutral as soon as possible. The reason for that is because in cervical neutral position, the vertebral column is open up to its greatest extent and provides the greatest functional space for the neural tissues. So if there is swelling and there is bleeding going on as a result secondary to injury, we have as much functional space to absorb that as possible. It's buying us time. So let's look at transfer implications then. We talked about we wanted to determine the likelihood that an athlete is going to be transported, because if we do that, there's a couple options that we have at our disposal. We can consider a log roll directly onto the backboard if we know this kid's going to the hospital. Then there's an opportunity there for us to eliminate some time, to eliminate some movement from repositioning multiple times, and we could log roll them right onto the backboard if we wanted to, if there's a high probability of transport. That would also require us to have availability of a long spine board. I don't have one on the sideline. I wait for EMS if I need a spine board. So I don't even have access to one. So log rolling onto a spine board wouldn't be an option for me. But it is an option that you could plan for, a legitimate option. The availability of skilled personnel, and that's primarily the reason I don't bother with it, is because I'm going to wait for the highly skilled people to come and help me log roll that person or help me reposition that person if need be. The transport and immobilization time. This is a big one because this is the debate that's going on right now about whether we put somebody on a long spine board. And I'm sure a lot of you have come across the protocol changes in EMS, where EMS will just show up to you and basically are telling you, we no longer put people on spine boards. We're going to put them on put a cervical collar on and put them on the gurney and transport them that way. Okay? So that's an important consideration when we talk about transfer implications. Because one thing you want to consider is how long is that person going to be on the spine board? In the professional setting, an individual that is put on a spine board is not going to be on that spine board very long. Okay? It's going to be 4 to 6 minutes that they're going to be transferred and off the field in about 4 to 6 minutes. And then from then, they're going to have a police escort to the emergency facility. And you can bet that an NFL football player is not going to sit in one of the trauma bays in the emergency room and wait for physicians to come by. You can bet that physicians are going to be waiting in the trauma bay for them, and they're going to be off that spine board pretty quick. Versus our kids, for me, if I transport somebody, it's going to be 6 to 8 minutes before they leave my field. It's going to be 25 minutes before they arrive at the level 1 trauma center. And it's probably going to be, an hour, maybe 2 hours before they're actually taken off that spine board. So that's where a lot of those implications, and that's why EMS doesn't want to transport on long spine boards often anymore, is because they're actually health risks to being immobilized on a long spine board for that period of time. So when you're looking at transfer protocols and whether you're going to use the spine board or not, consider that. That's going to play big into whether do you remove football equipment on the field or do you wait until they get to the emergency room. A lot of that is going to be based on the real-life situation that you're dealing with. How long is this kid going to be spine boarded? What type of trauma center am I sending him to, and am I sending him to people that have no idea what to do with him when they get there? Then maybe it is better to take it off here, okay? But in the professional setting, it's not so much the best case. We wouldn't want to take it off in the middle of MetLife Stadium when we could transport them to the emergency room and they go with a police escort and they have an athletic training escort that goes with them that helps them remove it in the emergency room. So that's not necessarily the best option in the pro setting. Okay, so you can kind of see where I'm going with this is that we have to make decisions based on the real life scenario that we're in at that time. Okay, so transfer implications and the mechanism for transport as well as the immobilization time and the benefits and the consequences of those decisions. That's going to weigh your decision on what to do, whether to remove the equipment now, maybe you remove some of the equipment, or maybe you wait until they're in the tunnel or in the ambulance, or maybe you wait until they're in the emergency room. Those are decisions that you need to be able to make based on the status of the cabin, and not because it's dictated to you by guidelines or a protocol. All right, so what does expert opinion say then? Okay, that's kind of some of the things that I've learned just in teaching the program. But what does expert opinion say? When we take these things around, what do trauma physicians say? What do paramedics say about all this kind of stuff? We know what the athletic training journals say. What does expert opinion about people that are actually doing this every day? What do they say? See, I took my glasses off because I was looking out, and now I can't see the screen, so it's pathetic. But most are likely to log roll directly onto, most are not likely to log roll directly onto a backboard, especially if it's a life-threatening situation. I think that's obvious. If it's a life-threatening situation, they're unresponsive, they're not breathing, or they're not responding to you, then obviously we don't know what the status of the cabin is. Log rolling onto a spine board is secondary to what our primary objective would be at that time. So again, mobilization and movement is secondary to critical care at that point. In a non-life-threatening situation, most still are not likely to transfer or log roll directly onto a spine board, mostly because they don't have a spine board or they're not comfortable doing that procedure without EMS. There's also the feeling that there's a reasonable chance that further assessment will find transport is not indicated. So unless it's an emergency situation, or unless it's a real obvious situation where they are going to the hospital, most people feel that if you log roll and you do a further assessment, chances are that athlete is going to be able to get up and walk off the field on their own. And now you've brought the backboard out on the field, created this chaotic scene. Nobody likes to see a backboard come out onto the field, and that just creates problems all the way around. So that's another reason that most will not log roll directly onto a backboard. Interestingly, trauma and neurospine doctors, they're not concerned about how you do it. And when we talk to most of these physicians, most of them, they don't care what you do pre-hospital. As long as you maintain safe handling practices, they don't care what protocol you use. They don't care whether they come to the trauma bay with all of their equipment left on, or whether they come with it all off. It really doesn't make any difference to them. It doesn't make any difference whether you flat lift or log roll. In the pre-hospital setting, they really don't care much about that. As long as you are using safe handling practices, as long as you are maintaining neurological status, as long as you're maintaining the cabin, they don't really care what procedure or protocol that you use. This is a very detailed, messy-looking flow chart that is it's online for you in that portal that I gave you the access code to, that you can look at a little bit more. This is our progressive algorithm that we use for on-field assessment, and you can take a look at that when you have some more time to go over that. When you actually start to read it, you'll see it's not as complicated as it looks. But I might suggest to you that your assessment takes on a similar approach that this algorithm does, and we call it a progressive algorithm because it starts with very minimal movement and allows a progression of more and more movement as you become more and more confident that the athlete is okay. It starts out with assessing the cabin, mechanism of injury, moves into neck pain, subjective neurological signs and symptoms in your neck assessment, and myotomes. But more importantly, that's kind of our classic textbook on-field assessment. More importantly, it moves on from that and provides another level of assessment in terms of being able to assess range of motion and those types of things before you let a kid up off the field. So take a look at that when you have an opportunity. And thankfully, most will walk off the field. We know that to be true. But what do we know about precautionary transport? What about when our assessment strategy, and that flow chart that I showed you, that flow chart is also built on what we call a philosophy of fuses. So much like a fuse box in your house, if a fuse goes off in the box, then you flip the light switch, the light doesn't go on. The same thing holds true in the flow chart, the spine injury flow chart. If at some point in your assessment you blow a fuse, or at some point in your assessment there is a sign or symptom of transport, that's a blown fuse. At that point, you know if you blow a fuse, you flip the light switch, your athlete's not getting up on their own. They're going to the hospital, they're going to be transferred to the emergency room. Okay? The important part of that is once you blow a fuse, your assessment stops. Now your job is to support the vital signs until EMS arrives to transport the athlete. Any more assessment that you do only opens the door for you to make a mistake because the pain level in the back of the neck that blew the fuse, maybe that was an 8 when you started. But now a couple minutes later, it's a 4, maybe it's a 5. It's not quite as bad as it was. The tingling in his arms going away a little bit, and now you open the door to make a mistake because it's in the fourth quarter, it's raining, there's only 2 minutes left in the game. If you pull the trigger on transport, activate the emergency action plan, you're going to be there a long time. It's going to be a long night. Nobody wants to do that, okay? And that's where the opportunity to make a mistake arises. Plus, to be honest, do we really care if the lesion is at C3 or C4 or C5, C6? We don't care where the lesion is. All we care about is there's an indication that there could be a lesion somewhere, could be an injury somewhere. We don't care where it is. So for us to do upper quarter screen, lower quarter screen, all that kind of stuff doesn't make any sense. So when you blow a fuse and you know that athlete needs to be transported, stop your assessment at that point, support the vital signs, and activate EMS and get them to the emergency room. So removal of all equipment in the pre-hospital setting. So what's kind of the status out there? What are people doing nationwide, if you will, across the country? What's the status of that, if you will? Well, the document that was circulated a few years ago suggests that we should be removing equipment in the field for a couple of reasons. We should be doing that prior to transport because it facilitates airway management. This may be true. Facilitates use of the automated external defibrillator. Could be true. You're better able to manage shock. That could be true. And you're able to apply a cervical collar. All of those things are true. But if we take a look at this in a different way, we have to consider the cabin, first of all, and what our primary objectives are, and then consider the environment and the venue that you're in. And I go back to examples from the professional setting. Their approach is a little bit different. Their approach is that we stabilize the athlete as best we can, and we get them out of the uncontrolled environment and into the controlled environment as quickly as possible. So for them to be in the middle of a stadium, and believe me, they're more than aware of the importance of proper care versus people that are watching. Okay, but there is that avenue, or there is that perspective of, hey, we have 80,000 people that are watching what we're doing, and another who knows how many that are watching us on TV. So there is a little bit of, let's get them stabilized and get them out of here, that we don't necessarily have to deal with. But maybe we do. We don't have 80,000 people watching us for the most part, but we do have maybe 4,000 watching us, or 400 or 500 that are watching us. And if we stay out there on the field too long, or if we start removing equipment from an athlete, what does that say to people that are in the stands? That's a bad scene, right? Nobody likes to see that. We must really be scared about what's going on. And that takes time. It creates concern. And the longer we're there and the more concern we create, what ends up happening? We start getting a lot of help. We start getting a lot of people that come out of the stands with their take on how things should be done from that point forward, right? So it's best, I think, overall, when you're considering what to do in this process, that one of the things that you're considering, in addition to the cabin, the status of the cabin, is consider getting that in. What's it take to get that person stable so that you can get them out of an uncontrolled environment, which is the game field, and get them into a controlled environment, which might be the tunnel, the stadium, going up the tunnel. Maybe it's in the back of the ambulance. Paramedics, if there's EMS and paramedics out there, that they'll know this, that they prefer the controlled environment versus the uncontrolled environment. What's the expert opinion poll say? I don't think I told you about the expert opinion poll, but on the website you'll see not only the references that you'll see there, but we have an expert opinion poll on all these questions that we're dealing with. And you can go on there and you can complete that poll. And that poll is basically a series of questions that say, hey, in this given situation, what is your preference? Under these certain situations, what is your preference for care and management? And the idea is that just nationwide, multidiscipline-wide, we all answer these questions. And as once you complete the poll, you can see the ongoing results of the poll. So maybe you transfer to a long spine board and send them to a trauma center. You can see what other people across the country are doing and what kind of the average response is. So if we look at that expert opinion poll, that poll is ongoing. We've been doing that for 3 years now, so it's kind of interesting to see that. If you look at that expert opinion poll, there's various approaches that seem to be asset-driven. And by asset-driven, I mean, what do you have at your disposal to care for that injured athlete, to complete those critical care tasks? So some will remove all the equipment right on field before they're even removed from the field, before they're put on the gurney, and before they're taken off the field. Some will do it in the tunnel or the rig. That's where they'll remove equipment. And some will wait and do it in the emergency room. And again, I don't think there's any right or wrong answer to when it should be done. I think it's your decision about what the most appropriate time to do that is. For example, if it's Friday night and it's November and you're in the middle of playoffs, that might be different here in Texas. I have to keep that in mind too. You don't want to remove equipment in upstate New York from an athlete in the middle of November if it's raining and it's the third quarter and he's sweaty. You start removing equipment from that athlete, he's going to get extremely cold. He's going to go from being really, really hot to extremely cold. Now you're dealing with hypothermia and other types of things. So those are things that we would have to consider. I don't know about November in Texas. Yeah. November where I am, it's freezing rain, it's miserable. I don't know, it's probably sunny and warm here, right? All year long. So that's exactly what I'm talking about, is that under different conditions, I'm going to respond differently than you might respond. So for me to tell you, me coming from New York, to tell you in November you should remove all the equipment from the athlete, or that you shouldn't remove it, maybe you should, because maybe it's a particularly hot day and it would be better for the athlete to have the equipment off. Those are decisions we have to make in real time. What about unstable and life-threatening situations? SMC's primary objectives approach says that our decisions based on what the status of the cabin is. We remove only that piece of equipment that becomes a liability to completing our primary objective. That's versus the all-or-nothing principle. How many people have heard of the all-or-nothing principle to equipment removal? All right? The all-or-nothing principle says if we remove the helmet from an athlete, we have to remove what? Otherwise, what happens? Head falls back into extension. Okay? Well, I can tell you that all-or-nothing principle is based on one research article that was done about, it's got to be 20 years now, So we're basing that on one research article that was done 20 years ago that found when we put somebody on an x-ray table and we had them in full protective gear and we took a cross-table lateral view of the cervical spine, it was lined up. Then we took the helmet off and we took that horizontal cross-table view and the head was in extension. Then we sat them up and we took the shoulder pads off, laid them back down and took a horizontal cross-table view, and voila, he was back in cervical neutral again. It doesn't happen that way on Friday. If I was to take anybody in this room, lay you face down and log roll you, guess what would happen when we log rolled you? Your head would fall into extension. If we took a fully equipped lacrosse player and put him face down and log rolled him and didn't do anything else, his head would fall into extension. If we then remove the helmet from the athlete, his head would fall into extension. Hockey, lacrosse, football, doesn't matter. If we remove the helmet and we remove the shoulder pads from the athlete, the head will fall into extension. So the head is going to fall into extension regardless. So that one study and that all or nothing principle does not hold water, does not hold up to our actual practical practice. Okay? So that's one reason I don't like the all or nothing principle. The other reason I don't like the all or nothing principle is because the all or nothing principle says if our athlete's not breathing and we try and remove the face mask from the athlete and we can't get the face mask off, what do we have to do? We have to remove the helmet from the athlete, right? We need access to the airway. Why are we removing the helmet from the athlete? It's because he's not breathing. It's because we need to breathe for the athlete. So we remove the helmet. Now the all or nothing principle says, what do we have to do next? We have to remove the shoulder pads. So now we cut the jersey, we cut the shoulder pad strings, we cut the straps, we pull the ripcord, we do all of that kind of stuff. We pull the jersey off, we pull the shoulder pads apart, we slide it out, and it's not easy. All of us know it's not easy to do. So we're working the shoulder pads out from underneath the athlete. The whole time we're doing this, what's our athlete not doing? The athlete's not breathing. So when you and I are at Walmart and we fall over and go into cardiac arrest or we stop breathing, we've got about 4 minutes of residual oxygen floating around in our bodies to get us through. So we got about 4 minutes that we can go without breathing before things really start to go bad. Athletes have a little less than 4 minutes because they're using oxygen, they're exerting themselves, they're using oxygen at a higher rate. So we have a little bit of time, but we don't have a whole lot of time. So if it takes us 30 seconds to get to our athlete that's not breathing, it takes us another 30 seconds to assess that they're not breathing. We get the helmet off, that's another 30 seconds. And then we mess around with the shoulder pads. All of a sudden, we're really starting to encroach on that amount of time that we have with residual oxygen floating around. So that's what I mean by, in a life-threatening situation, we remove only that piece of equipment that is a liability to what our primary objective is at that time. Remove the helmet from the athlete, start rescue breathing, and then we're in our high-quality CPR cycle. Then, if we go down and we check the pulse, and there's no pulse, now what's in our way? Now the shoulder pads are in our way. Do we have to remove the shoulder pads? No. What's our primary objective at that point? Our primary objective is to initiate compressions and get the automated defibrillator on the athlete and defib the athlete if it's a shockable rhythm. All right, if we now cut the jersey, shoulder pad strings, straps, pull the ripcord, start pulling shoulder pads out from under them, all that is delaying what? Onset of compressions and the automated defibrillator. All we need to do is cut that stuff, spread the shoulder pads, start compressions, put the defibrillator on, and shock. Now we're in high-quality CPR. Shock, breathe, shock, breathe, shock, breathe, the whole CPR thing. And then, because we're so good at what we do, we're going to get it. It's going to be a shockable rhythm. We're going to shock them. We're going to get. They're going to get back into a normal rhythm. Then we can remove all of the equipment, log roll them, put them on a spine board, strap them, and send them to the hospital. Okay. But we know from the chain of survival, and we know from ACLS protocol that we have to initiate compressions as soon as possible, and we have to maintain those compressions and minimize the delay in those compressions. So anything that we do that messes around with the equipment that delays that moves us away from what ACLS protocol says is in the best interest of that athlete. So we remove only that which is a liability to completing the primary objective. Remove all the equipment after it's stabilized, and we can do that. I think I mentioned this already, the flat torso versus the torso lift technique. Okay, so what's kind of the expert opinion on that, whether we should do, because that's kind of a battle in the literature. There's one camp over here that says the torso lift should be the technique used to remove equipment. There's another camp over here that says that much movement is too much movement. I'll tell you what expert opinion says across the country for the most part. I think everybody likes to try and remove equipment when they're just laying down. But if you get a really big athlete, or you have an athlete whose jersey is tucked all the way in and maybe even attached to the back of the pants, then that's going to be a little bit more difficult. Then you might have to do a flat lift. So what I've been seeing, interestingly, this year, I would say this year in the month and a half that we've been doing the educational programming, it's been interesting because this is the first I've seen this trend, is that the trend seems to be try to remove all the equipment from the person when they're just prone, or I'm sorry, supine, and if that doesn't work, then do the torso left technique to get the equipment off. So again, it kind of flows with the red kit philosophy that we have. Have both of those techniques at your disposal, but more importantly, the cognitive understanding to know when is most appropriate. Talked about establishing and maintaining cervical neutral position already. All right, so as we walk a little bit further through the cabin, we do our airway. What about airway management? Face mask versus helmet removal. This is interesting as well, because over the last couple of years, we've had a lot of debate on face mask removal. We've had a lot of changes in helmet technology over the last couple of years, mostly concussion-driven, but spinal cord injury and some other emergency management protocols have benefited from that new technology as well. Generally, face mask removal follows what we call the combo tool approach, where we use either a power screwdriver or the quick release mechanisms, quarter turn by shut or the quick release by Riddell, as a first line to get the face mask off. Power screwdriver and those quick release fasteners have been shown to be associated with the least amount of time and the least amount of movement. But interestingly, over the last couple of weeks, I've actually seen a trend towards if someone is in respiratory distress, not even worrying about the face mask, defaulting right to helmet removal. And I can't argue with it when I see it unfold. Because again, think about it from this perspective. If your athlete is not breathing, it's going to take probably up to a minute to get that face mask off. Quick release fasteners, when they work really well. But they have a failure rate very similar to the fixed screw and T-nut failure rates. About 33% of the time, that hardware system will fail on one of those four fasteners. So even on a good day, you're probably looking at 30 seconds to 40 seconds before you're going to get that face mask off. Some people across in this protocol feel that the heck with that. Let's just remove the helmet. We'll pack and fill underneath to keep the head from falling into extension and start breathing for the athlete. And I don't know if I can argue with that. And I can't tell you from a literature standpoint, there's no literature out there to back it, that it's faster and associated with the least amount of movement or less movement than face mask removal. No one's done that work yet. But I wouldn't be surprised if someone starts doing that work, and I wouldn't be surprised if we find that helmet removal is the fastest and most efficient way to get at that airway. And I think that's driven by new helmet technology. Those helmets come off extremely easy. With the right protocol for removing a helmet, they come off very, very efficiently, probably more so than face mask removal. You'll see here that in the literature as late as 2016 and 2015, some research was showing that helmet removal was preferred with respect to time, but not to movement. And I think research is going to start showing that with proper protocol, that movement is going to be kind of a factor of practice. What I might suggest to you, and what we find to be very effective in terms of competency benchmarks when we do final checkouts with teams completing critical care tasks, what we find is a really good first-line approach is work on that face mask while you're doing CPR, work on that face mask until you're about to miss the second cycle of CPR. Okay, because remember, we have about 4 minutes of residual oxygen, somewhere in that range. So if you're doing chest compressions and you're doing your 30 compressions and you're coming up when you should deliver 2 breaths and you miss that because the face mask isn't on, I wouldn't worry about it. Just continue doing chest compressions. Don't stop doing compressions. Continue with the compressions. Now, if you start to get to the point where you're going to miss the second cycle of rescue breathing, then I think you're in a situation where it's time to make the decision about whether to pull the hat. Okay, so that's always been our benchmark in terms of our competency checkouts. And that's driven by how much time and residual oxygen an average person has and how long a cycle of CPR takes. The other trend that I see most recently is the heck with that. If he's not breathing, we're going to pull the hat and start to breathe for the athlete, which I can completely understand that philosophy as well. So that philosophy, I would say, is driven by expert opinion. But as far as, if you want to look at evidence-based practice, your Class 1 or Class 2 evidence, there's not a lot of support for that yet. But I think you're going to start to see that. Now, when you're performing ventilations for an athlete, no helmet is preferred to a helmet. So here again, what research is showing is that when you have to do CPR or rescue breathing is more efficient with the helmet off. So maybe there is some evidence pointing to the need to take the helmet off. But I can tell you for the most part, and I'm not saying that this is true in every case, but I would say generally, if you allow me to make some observations, most paramedics would rather have the helmet off if they have to do any type of airway management. And certainly bag valve in somebody, which is BLS protocol for that you and I are able to do, is certainly, no, I can't say that. I can't say that bag valves are that much more challenging with the helmet on. But I would say that paramedics, for the most part, when they're doing ACLS, want the helmet off. Bag valve is preferred to a pocket mask, and let's be honest about this as well. As athletic trainers, should we really be using CPR masks? I think it should all be our standard that I don't have a CPR mask in any of my kits. I have bag valves. There isn't any reason. It's all within our Practice Act, and it's all established that it's expectations in our profession that we should be able to bag valve. So realistically, for us, at the level of care that we're providing, I don't think we should be using CPR masks. My opinion, that we should all be using bag valves. And so literature does support that bag valve is preferred to pocket mask in terms of ventilation. We know that the chin strap does interfere with our ability to perform ventilation, so when it comes to question about whether we remove the chin strap, that question always comes up quite a bit. Generally speaking, ventilations are improved when we have the chin strap removed. There is considerable research that has found that 2-person ventilations is more effective than 1 person. So when we're talking about our critical care triangle, what you should plan is for 2 people to be doing the bag valve if possible. Paramedics are really good at being able to hold the bag valve and ventilate at the same time with 1 person doing that. Fortunately, you and I don't do that stuff very often. We don't have to bag valve very many people. It's not something that we do on a daily basis. So we're not quite as good at it. So I think that's what I do anyway. I plan to have 2-person bag valve because I know I'm not good at holding the airway open, holding a good seal, and squeezing the mask all at the same time by myself. 1 person creating the seal with the bag, maintaining an open airway, the other person squeezing the bag seems to work out much better. And again, that is grounded in evidence. What about compressions then? Compressions over shoulder pads are ineffective. That's been shown in an article as early as 2011. Shoulder pad removal has been found to be easier with the ripcord system. And the second article that I put up here, the one that was completed in 2015, I like that because the first article I have up there by Kordecki in 2011, I know that author pretty well, and I know him to be a stand-up guy, so I don't think there's bias there, but he did invent the ripcord system. So there is, I don't even mean to suggest that he would do that. But what I like is the follow-up article in 2015 he was not a part of, and it did validate the first study that he was a part of. So that's why I put that up there. I don't mean to suggest that he's biased. I'm just saying that, from a peer review standpoint, there is that bias there. That bias is kind of washed away by the follow-up 2015 article. Removal of equipment delays completion of critical care tasks. That's a paper that I was an author on that was published in the journal in 2015. And that kind of leads to some of the philosophy that I've been talking about earlier on, that when we deal with equipment, when there's other critical care tasks that we should be dealing with, we're delaying the completion of those critical care tasks. So what we found was, if you remove the helmet from the athlete and keep the head from falling into extension by using what we refer to as pack and fill towels, packing and filling underneath the head, between the head and the turf with towels, keeps the head from falling back into extension, we can go on with rescue breathing versus going back and removing the shoulder pads from the athlete. There has been a question in the literature as of late regarding the application of cervical collars and the use of cervical collars. As far as in our setting, what we need to be most concerned about are the articles that are over there underneath blunt force trauma. You'll see that we found, or some articles in 2010 found that there was abnormal separation in the vertebral column as a result of application of a cervical collar. There was also movement during the application and removal process, and they provided insufficient support. But the interesting thing about all of these findings is that with practice of application technique of cervical collars, most of these were washed away. So a lot of this is just a practice effect. We can minimize or marginalize all of those effects, adverse effects of using a cervical collar, just by being better at applying a cervical collar. Okay, so how about then preparation for transport? There's information, or there are studies out there that suggest that we should eliminate the log roll transfer, as a transport mechanism or transport protocol. And I take issue with that, because there are going to be times, as I said, when we're going to pull the log roll out of our red kit, and there are times when the 6-person lift may be more appropriate to pull out of the kit. You'll see here a number of articles in 2007, 2008, and there's been more since then, that support a log roll, support a 6-person lift over a log roll in terms of the amount of movement produced. But again, as this image suggests, we haven't been very successful at doing 6-person lift on the ice without a significant number of people that are good at doing it. And even the paramedics that we work with are a little on the iffy side about wanting to do a 6-person lift on the ice. I'm not saying that it's wrong. I'm just saying that if that is if you like the 6-person lift and you want to do that on the ice, I'm just suggesting that you do a good job of practicing that. And I suggest that you do that with EMS. One of the things I'll allude to here later on in a different topic area, we actually did some practicing with EMS on some protocol review stuff on the ice. And what do you think happened as soon as EMS entered the ice rink? Anybody venture a guess what happened? They went down. The 2 of them went down and took the gurney with them. I got it on tape. I can prove it to you. Because I let the cameras roll the whole time. Like, no, don't stop the cameras. It's too good. So there are those concerns with ice. And again, those are things that you have to consider when making the decisions. Log roll push is preferred to the log roll. Here you'll see we're set up on the ice to do a log roll push maneuver. And this is where we have someone on the other side of the patient or of the athlete, and their responsibility is to more closely guide them by pushing on the way over, but more importantly, on the way down as they come into a supine position to help ease that transition over a little bit. And interestingly, especially with ice hockey, maybe I should even quantify that more, with ice hockey, what we find is, especially in goalies, when you bring a goalie up to parallel or up to perpendicular with the ice, you can bring them up pretty easily, but as you start to bring them over onto the supine position, when they start to go towards supine, you get to about 30 degrees, and all of a sudden that equipment slips on the ice. So you're fine up to about here, and then you start to come over into transition, you get to about 30 degrees, all that equipment slips on the ice, and they fall from 30 degrees down to the ice. And what we find with the log roll push maneuver is that we're able to mediate that. What I've seen most recently is a trend towards kind of a hybrid approach, if you will. What we're finding is that a lot of teams that have traditionally used a 6-person lift to get an athlete onto a spine board, when we actually pull a very large athlete over and actually practice that technique on a very large athlete, we find that the 6-person lift doesn't always work out so well, even with a team that's been using the 6-person lift for quite a while. So interestingly enough, over the last maybe year, I've seen where a lot of teams are using a 6-person lift on a small person, but using a log roll on a larger person. So maybe that could be something that you would consider in your emergency action planning. Okay, but again, they're not saying that we're only going to log roll or that we're only going to flat lift, but rather we do a hybrid approach depending on the situation that we find ourselves in. Long spine board complications, we touched on this a little bit earlier. In light of blunt force trauma mechanisms, do the benefits outweigh the risks? And a lot of times what you'll see, if you look at these EMS protocol changes, if you're reading about that, I want you to read the literature a little bit more closely. If you're reading that